Welcome to Easy Endo Prep's Endo in a Bite. I'm Dr. Sumbul Beg, and this podcast is your quick study snack designed for busy endocrinologists who want fast, board-relevant content that actually sticks. Whether you are preparing for initial certification, recertifying, completing the LKA, or simply staying sharp in clinic, this podcast is built for you. If you want my full board-focused system, visit easendoprep.com, where you can enroll in the complete Easy Endo Prep Board Review course or start a free trial. Let's talk about a common scenario. You start a patient on semaglutide. At first, everything looks encouraging. Glucose improves. Weight begins to fall. Cardiometabolic risk starts moving in the right direction. Then about 2 weeks later, the patient sends you a message. They feel nauseated. Sometimes they feel full after only a few bites of food. And now they are asking whether they should stop the medication. This is a situation many clinicians encounter. So the question becomes this: should we stop therapy, or is there a better strategy? Because the reality is this: semaglutide provides substantial clinical benefit. It improves glycemic control. It promotes meaningful weight loss. It reduces cardiovascular events, and it also improves kidney outcomes. So stopping therapy too quickly may mean losing one of the most effective metabolic treatments we have. So how should we approach this? Let's walk through it. To manage these symptoms effectively, we first need to understand why they occur. Semaglutide slows gastric emptying. That delayed gastric emptying contributes to satiety and weight loss. But it also means that food remains in the stomach longer. And that leads to an important physiologic effect. Large meals create gastric distension, and gastric distension is one of the main triggers for nausea, so the same mechanism that promotes weight loss can also produce gastrointestinal symptoms. Now that raises another question. Why do symptoms often appear during dose escalation rather than during the first dose? The answer is dose dependence. Higher doses produce stronger effects on gastric emptying, so symptoms commonly appear when therapy is started or when the dose increases. But here is an important clinical observation. In many patients, these symptoms improve with time if therapy is continued. So instead of stopping the medication immediately, the goal is usually to improve tolerability. In practice, there are 3 strategies that work particularly well: dietary adjustments, slower dose titration, and symptom-directed therapy. Let's walk through each of those. First, dietary strategy. Meal size matters. Because gastric emptying is delayed, large meals increase gastric distension and worsen nausea. Patients should eat smaller portions. They should eat only when hungry, and they should stop eating when they begin to feel full. Another useful strategy is avoiding large amounts of fluid during meals. Drinking large volumes while eating increases gastric distension. Instead, patients should drink fluids between meals. Certain foods also tend to worsen symptoms. High-fat foods, spicy foods, very sweet foods, and many processed foods. Reducing these foods early in therapy can significantly improve tolerability. Now let's talk about managing specific symptoms. If diarrhea occurs, hydration becomes important. Patients should increase fluid intake. However, they should avoid drinks that contain large amounts of sugar or artificial sweeteners because those can worsen diarrhea. Dietary changes can also help. A short period of bland foods and lower fiber intake may improve symptoms. And there is an important nuance here. If diarrhea is the primary symptom, a high-fiber diet may actually worsen the problem. Constipation requires a different strategy. Supportive measures include adequate hydration, soluble fiber intake, regular physical activity, and a balanced diet. Often these simple interventions are enough. Now let's move to the second management strategy, slower dose titration. Many gastrointestinal symptoms occur when the medication is escalated too quickly. Holding the current dose longer often allows the gastrointestinal system to adapt. For example, if symptoms develop after increasing from 1 milligram to 2 milligrams, returning to the previously tolerated dose and maintaining that dose longer may improve tolerability. Sometimes extending the interval between dose increases to 2 to 4 weeks can make a significant difference. But that raises another practical question. What if symptoms persist even with slower titration? That brings us to the third strategy, symptom-directed treatment. Antiemetic medications can help with nausea and vomiting. Antidiarrheal medications may help if diarrhea develops. And stool softeners may help with constipation if supportive measures are not enough. There is another practical strategy sometimes used in clinical practice. Microdosing with multi-dose pens. Patients count the number of pen clicks to administer intermediate doses between standard dosing increments. This approach is not endorsed by the manufacturer, but the rationale is straightforward. Smaller dose increases allow a slower and more gradual titration. For example, 24 clicks corresponds to approximately 0.67 milligrams, 30 clicks corresponds to approximately 0.83 milligrams, and 42 clicks corresponds to approximately 1.17 milligrams. These intermediate steps can allow gradual dose escalation every 2 to 4 weeks until the target dose is tolerated. Another question that sometimes arises is whether switching to oral semaglutide might solve gastrointestinal symptoms. In general, this does not solve the problem. Oral semaglutide produces similar gastrointestinal adverse effects, and it typically results in less weight loss and slightly weaker glycemic control compared with the injectable formulation. So switching formulations usually does not address the underlying issue. And now let's shift to another important clinical scenario, pregnancy planning. Semaglutide should be discontinued before attempting conception. The recommended washout period is approximately 8 weeks, and the reason relates to pharmacokinetics. Semaglutide has a very long half-life, roughly 196 hours. Because of this long half-life, the medication remains in the body for an extended period after discontinuation. There is limited observational data regarding pregnancy exposure. A Danish registry review identified 32 pregnancies with first trimester semaglutide exposure. In that analysis, there was no increased risk of major congenital malformations compared with insulin-exposed or unexposed pregnancies. However, there were higher rates of preterm birth, large for gestational age infants, neonatal hypoglycemia, and neonatal jaundice compared with unexposed pregnancies. And there is an important limitation, and there are no randomized trials evaluating the safety of semaglutide during pregnancy. Because of this lack of evidence, semaglutide is not approved for use during pregnancy. After discontinuation, glycemic control may worsen. In those situations, metformin or insulin therapy may be needed to maintain adequate glucose control. Optimizing glycemic control before conception remains extremely important for both maternal and fetal outcomes. Finally, let's briefly discuss another increasingly important role for semaglutide: kidney protection. Patients with type 2 diabetes frequently develop chronic kidney disease due to hyperglycemia, inflammation, oxidative stress, and hemodynamic stress within the glomerulus. Therapies that reduce these stresses can slow the progression of kidney disease. Semaglutide contributes to kidney protection through several mechanisms. It improves glycemic control, it promotes weight loss, it lowers blood pressure, and it may also have anti-inflammatory and antioxidative effects. Evidence for kidney benefit first appeared in cardiovascular outcome trials. In the SUSTAINED 6 trial, semaglutide reduced the risk of new or worsening nephropathy by about 36% compared with placebo. Much of this benefit was driven by reduced progression to macroalbuminuria. More definitive evidence came from the FLOW trial. This large randomized trial evaluated semaglutide in patients with type 2 diabetes and chronic kidney disease. The study demonstrated reduced risk of kidney failure, sustained decline in kidney function, and renal death. It also showed reductions in cardiovascular events. Semaglutide is recommended because of its cardiovascular and renal benefits. So let's return to our patient. They started semaglutide. 2 weeks later, they developed nausea and wanted to stop therapy. Instead of discontinuing the medication, we adjust meal size, we slow the titration schedule, And we treat symptoms if needed. In many cases, symptoms improve and the patient remains on therapy, and that allows them to continue benefiting from one of the most effective therapies we have for cardiometabolic disease. So the key takeaways are simple. Gastrointestinal symptoms with semaglutide are common, but often temporary. Dietary adjustments and slower titration frequently improve tolerability. And maintaining therapy whenever possible allows patients to benefit from improved glycemic control, weight reduction, cardiovascular protection, and kidney protection. That wraps up this episode. Inspo for this episode was taken from ESAP 2026. These were the points that were mentioned, and I found them clinically relevant. If you missed anything, don't worry. I've taken all the notes for you. You can get a clean summary with headings and bullets delivered straight to your inbox. Just head over to www.easyendoprep.com and sign up for the newsletter. Keep tuning in. I release a podcast every Monday, and let's continue to learn one bite at a time.